Hi everyone, my name is Dr. Fatima and I'm the director of the PEBC courses here at PharmAchieve. Today I'm going to be talking about tailoring COPD management and more specifically what happens when your first or second line of therapy fails. What do you do next? How do you improve on your treatment? Okay, so let's get started. So first let's start with what happens when you have shortness of breath and you're already on some sort of therapy. So first of all, if you're on a LAMA and you still have shortness of breath, add a LABA. If you're on a LABA and you have shortness of breath, add a LAMA. Very simple, and we see that in previous therapies where we step up to a different class of therapy. So that's that bit. If you're on one, step up to the other, and now you're on a combination. Another thing you can do is, if you're on a LABA or a LAMA and you are experiencing shortness of breath, you as the pharmacist can speak to the patient, assess their inhaler technique. Are they using it correctly? Which inhalers are they using? As we know, inhalers are hard to use, especially if the patient has dexterity issues. A lot of times in the elderly or patients who have Parkinson's, for example, they may not be able to use the inhaler. So look at the patient, ask them to show you how are they using the inhaler, how often are they using it, etc. Another thing you can do is to maybe switch the molecule. So they would still have a LAMA and a LABA, but choose a different type of LAMA or LABA. And whether that's both drugs are different in a combination inhaler or whether you change one and you keep the other the same, see if that helps. So remember, you're still within the LAMA and LABA class, but you're switching one or two molecules to see if the patient responds a bit better. So that's simple enough. Shortness of breath, if you're on one and it doesn't work, add another and assess technique. Now let's talk about exacerbations. So that can be a little more complicated, but I am going to walk you through this. And for your exam, I would stress that you only need to know the first few lines of therapy. So keep that in mind and also focus on the drug therapy properties. So what is it about the drug that makes it work? What are the side effects, the indications, etc.? So for exacerbation, let's start at the top and work our way down. Now, the patient is on a LAMA or a LABA. What do they do next? They're still experiencing exacerbations. Now, if their eosinophils are less than 300, so that's this bit here, then similar to what we did in the shortness of breath section, we're going to add the other inhaler on. So if they're on a LAMA, we're going to add a LABA. And if they're on a LABA, we're going to add a LAMA. Simple combination therapy. Now, let's say their eosinophils are a bit higher. They're greater than or equal to 300. Now, what do we know about that? We know that in higher eosinophil counts, the patients are more likely to respond to an ICS. So at that point, instead of just adding a LAMA or a LABA, if we know that they're on one drug and their eosinophils are greater than or equal to 300, we're going to add the other drug and an ICS. So they go from one drug or one molecule to three. Triple therapy, okay? So remember, if it's less than 300, they can try dual therapy, but if it's greater than or equal to 300, they go straight to triple because we know that patients respond better to ICS when they have higher eosinophil counts. Okay, so that's that bit, and now we are at this point here. So let's say the patient is on triple therapy. So they're on a LAMA, they're on a LABA, and they're on an ICS, and they're still experiencing exacerbations. Now what do we do? So at this point, there's a few options. So the patient has an FEV1 of less than 50% and they have chronic bronchitis. You would think, okay, you could go with roflumilast. Another reason to go with roflumilast is if the patient has had an exacerbation already in the last year. Okay, in the last year. Then you would think, okay, roflumilast would be a good option. On the other hand, you could try azithromycin. Now, before you choose something like azithromycin, you would want to make sure that they do not smoke, okay? And you would also want to make sure that their QT interval is not prolonged and that their hearing is not impaired. Because as we know, azithromycin can cause hearing impairment. So if the patient is already susceptible to that or they already have hearing impairment, we would not use azithromycin. And finally, we want to check their MAC status. So that's it for exacerbations and shortness of breath, and that is how you would step up therapy in COPD. So on the exam, what I really want you to focus on is this bit here. So what to do when you have shortness of breath. Very simple, just add on the other molecule that you don't have and look at inhaler technique. And for the exacerbation bit, I want you to think about the eosinophil count. So remember, the key takeaway is the higher the eosinophil count, the more likely the patient will respond, or the better the patient will respond to ICS, and know the conditions of when to reuse roflumilast and when to use azithromycin.
So today we're going to be talking about relative risk. And what do I actually mean by relative risk? So relative risk is going to be a measure that basically compares the probability or risk of some sort of outcome between two different groups. Okay, so what do I mean by an outcome? This is usually some sort of negative outcome, either a side effect or some sort of disease. And we are comparing the risk of this outcome between our two groups. We're looking at an exposed and an unexposed group. So when I talk about exposure, what I'm referring to is exposure to some sort of risk factor or a drug, for example, right? So the relative risk is going to be something that you often see in things like cohort studies, or randomized control trials. I'm just going to abbreviate that as RCT. And so once again, we're basically looking at two groups of people. One group has been exposed to some sort of risk factor or some sort of drug. The other group has not. And then we're going to be following these study participants along and seeing who develops an outcome and who doesn't. Now, to calculate the relative risk, you're going to need what's called a contingency table. So you're going to see that on the left here. You want to make sure that you set up this contingency table properly, because the equation that you'll see here uses the letters A, B, C, D, which you're going to find on this table. But if you don't set up the table properly, then the equation can't give you the correct answer. So with our contingency table, you basically want to set it up such that you have exposure on the top row here. Non-exposure is going to be on the bottom row. And then you're going to have outcome on the left column, no outcome on the right column. Now, this seems like a lot to take in. Let's use a bit of an example. Hopefully things will make a little bit more sense. So let's suppose that a research group is going to be looking at some sort of new drug. Okay, so the drug is going to be the exposure. And the purpose of this drug, hopefully, is going to be to reduce the risk of chronic kidney disease, or CKD. So our outcome in this case is going to be chronic kidney disease. And of course, if you don't develop the outcome, which would be a good thing, that would be participants who do not develop CKD over the course of the trial. With our contingency table, A is going to represent the number of people who have been exposed to the drug who do develop CKD. Okay. B is going to be the number of people exposed to the drug who do not develop CKD. And likewise, C is going to be the number of people who were not exposed to the drug who did develop the outcome. And D is going to be the number of people not exposed to the drug who also did not develop CKD. Now, you'll notice in the formula that there are two big terms here. Okay, you have A over A plus B. You also have C over C plus D. And so if you don't like this A, B, C, D business, what's another way we might be able to think about it? If you look at our contingency table, right, what is A plus B? A plus B is just going to be the total number of people in our exposure group, right? We have A, who are the people who do develop the outcome, and B, the number of people who do not develop the outcome. But A plus B is just going to be the total number of people in our exposure group. So this term, A over A plus B, this is basically going to refer to the proportion, or the percentage, of people in the exposure group who do develop the outcome. So the percentage of the outcome in our exposure group. Likewise, C over C plus D, this is going to be the percentage of the outcome that is present in the non-exposure group. And what we're doing with relative risk is we're basically going to be comparing these two proportions, and that will basically tell us, does the exposure have a higher risk of causing this outcome? Does it have a lower risk of causing the outcome? What is the situation, right? So let's use a bit of an example. Let's put some numbers in, and hopefully this will be a bit more clear. So let's suppose we have our trial, right? We're still looking at this drug to prevent CKD. I'm just going to clean up the table a little bit. And let's suppose that we have 20 people who did receive the drug who developed CKD. 60 people received the drug, did not develop CKD. And among the people who did not receive the drug, let's say 30 of them developed CKD and 90 of them did not develop CKD. So if we want to use these numbers in our formula here, what we would have to do is calculate our proportions, right? So A over A plus B, we're just simply putting the numbers in. So A is 20, B is 60, and that will give us a total of 20 over 80, which is equal to 0.25 or 25%. Likewise, C over C plus D, that is going to be 30 over 30 plus 90. In other words, 30 over 120, and that's also going to be 0.25. If we wanted to calculate the relative risk, we would just basically do this term, 0.25, divided by this term, which is also 0.25, and that will give us 1. What does that tell us? Okay, so we have these different numbers here between the exposure and the non-exposure, just in terms of who developed CKD and who did not develop CKD. But when you actually run the numbers, you'll notice that the proportion of people who developed chronic kidney disease is going to be the same regardless of if they received the drug or not. Right? It was both 25% in each case. So that suggests that the exposure, so the drug in this case, did not have much of a bearing on whether or not patients developed CKD, right? Because you'll notice the same proportion present in the non-exposure group. So if our relative risk is equal to 1, that suggests that the exposure does not affect our outcome. Let's switch up some of the numbers and see what we're looking at in a different case. So we're only going to switch up A and B in this case. And so let's suppose we have 40 people in our exposure group who did develop CKD and 60 people in the exposure group who did not develop CKD. So if we want to do A over A plus B once again, that will be 40 over 40 plus 60, which is equal to 40 over 100, or 0.4. If we want to calculate the relative risk there, that would be 1.6, right? 0.4 divided by 0.25. Now, in this case, our relative risk is greater than 1, so what does that tell us? Basically, we know for a fact that 40% of the participants in our exposure group developed CKD versus 25% in our non-exposure group developed CKD. So that suggests that the exposure, or the drug in this case, is actually going to increase the risk of developing chronic kidney disease. And the opposite is also going to be true. Let's say if we had a lower proportion of patients in the exposure group who developed CKD, that suggests that the exposure is going to decrease the risk of our outcome, in this case again, being chronic kidney disease. So let's wrap this up with a little bit of a sample question. we have a clinical study that is going to be conducted to evaluate the effectiveness of a new anti-hyperglycemic medication. So we're managing blood sugars here. The study is going to enroll 1,000 participants in total. We have 500 participants in the placebo group and 500 in the experimental group. So the experimental group is going to be those who receive the medication. Okay, they're going to be our exposure group. The placebo group, they're being exposed to sort of a fake medication or like a sugar pill. So they're not actually receiving any drug, it's just a fake medication. So among those who received the new medication, 80 of them experienced symptomatic hyperglycemia. And in contrast, 100 participants in the placebo group experienced the same episodes of symptomatic hyperglycemia. So what is the relative risk in this case? Our first step, if we want to calculate the relative risk, is we need to build that contingency table, right? And so recall, we need to have our exposure on the top row. Exposure is going to be the drug group. Our non-exposure is going to be our placebo group, and that's going to be our bottom row here. Left column is going to be outcome, which we're just going to call increased blood glucose, or BG. And our no outcome is going to be those who did not experience these episodes, right? So we can even mark the corners with our A, B, C, D, if we would like. And now we just need to think about what the question is actually telling us. So 80 people in our experimental group, or the exposure group, have experienced symptomatic hyperglycemia. And we know there are 500 people assigned to the experimental group to begin with. So that tells us that we have 80 people that would be in this A group. And B, we know that 500 people total were in the experimental group. We would subtract those who did experience hyperglycemia, and that will give us 420 as our B value. We're going to do the same thing with C and D, right? So C, in the placebo group, 100 people experienced this hyperglycemia. And so D is going to be everyone else in the placebo group who did not experience hyperglycemia. In this case, that's going to be 400. Okay, now we can go ahead and calculate our proportions. That will tell us the relative risk. So our numerator is going to be A over A plus B. In other words, the proportion of people in the drug group who did experience hyperglycemia. That's going to be 80 divided by 80 plus 420, which is equal to 80 over 500, or 0.16. We can do the same thing for the bottom, and that's going to give us 100 over 100 plus 400, which is equal to 0.2. So our relative risk, we're going to take our numerator, 0.16, divide that by our denominator, and that gives us a final value of 0.8. Okay, so what have we learned from our contingency table? Well, we figured out that 16% of our drug group experienced symptomatic hyperglycemia, and 20% of the placebo group experienced symptomatic hyperglycemia, right? So that's the A over A plus B and our C over C plus D. The relative risk is going to be 0.8. And so since this value is less than 1, that suggests that the exposure, or the drug in this case, is actually lowering the risk of symptomatic hyperglycemia. And so that should about do it for this session on relative risk.
Here we have a review chart for all of the different branches of the health portfolio of the Ministry of Health. So here we have Health Canada, and under Health Canada, we have the Health Products and Food branch. And under here, we'll have the Pharmaceutical Drug Directorate, and this directorate governs all prescription medications in Canada. Marketed Health Products Directorate, and this is what represents all of the drugs that are marketed on the Canadian market. Then we have the Office of Nutrition and Policy and Promotion, and this is what promotes health promotion, recommendations for things to keep Canadians healthy and safe. We have the Natural and the Non-Prescription Health Products Directorate. So here we have Pharmaceutical Drug Directorate, and then here we have Natural and Non-Prescription. These two categories of drugs are treated differently, and they have individual directorates that govern them. And finally, we're going to be having Biologic and Radiopharmaceutical Drugs Directorate, and these are going to govern biologics, human products, cell tissue, plasma, things like that will fall under this Health Products Directorate. The Public Health Agency of Canada is also going to be another portfolio under the health portfolio. The Canadian Food Inspection Agency is another portfolio. The Canadian Institute of Health Research, now this is what governs all drug-related health research. This is the portfolio that is going to govern all of those things that are happening. And finally, we're going to be having the Patented Medicine Price Review Board. And here it is that we'll find that this ensures that patented medicines or brand name drugs that are entering the Canadian market for the first time are fairly priced. So this is pretty much just an overview of all of the different portfolios under the Health Ministry. Let's review the drug approval process for drugs in Canada. Now, the first thing that needs to happen is that the pharmaceutical manufacturing company needs to submit what is called an NDS. And an NDS is a new drug submission. And this new drug submission will be submitted to the Health Products and Food branch under Health Canada portfolio of the Ministry of Health. Now, this file is then going to have to be approved for the appropriateness, where all the details reviewed in the new drug submission is going to be reviewed by a committee, and they're going to see if it is that this drug meets the necessary requirements for drugs for sale in Canada. If it is found that the benefits of the drug outweighs the risks and that it's going to be causing more good than harm to the citizens of Canada, then this drug is going to be provided with what is called a NOC code and a DIN number. Now, a NOC code stands for the Notice of Compliance, meaning that the drug has now met the requirements necessary for this drug to be sold in Canada. If it is that the review committee thinks that additional information needs to be submitted in order to fully approve this drug, then it's going to be provided with what is called a NOC/C, which is a conditional notice of compliance, and some additional information is going to be needed to be submitted before it is that the drug can be fully authorized to be sold in Canada. Once it is that the drug goes through these 3 steps, then it is that we will be at step 4, where it is that the drug can now be sold.
Hi everyone, my name is Irini. I'm a pharmacist and I'm also an instructor here with PharmAchieve. Today I just want to do a quick review with you guys about blood pressure targets in hypertension. Now, this topic can get a bit confusing because sometimes your patient presents with multiple comorbidities and sometimes they would require certain blood pressure targets. So let's go ahead and divide our patients into 4 main categories. The first category we have is our high-risk patient. According to Hypertension Canada, in order to be categorized as high risk, you need to fulfill 3 main criteria. The first criteria is the age. The patient needs to be at least 50 years of age. Their systolic blood pressure needs to be at least at 130 millimeters of mercury, and the third criteria would be one of those 4. So they can have clinical or subclinical cardiovascular disease, so things like myocardial infarction or peripheral artery disease. They can also have chronic kidney disease. They can be 75 of age or older, and their 10-year global cardiovascular risk is 15% or higher. Once the patient satisfies those 3 categories, we would want to initiate blood pressure therapy for them once their systolic is at 130 or higher
And because they are at higher risk, we're going to target their systolic to be less than 120. So we're a bit more strict because they are at high risk. The second category is patients with diabetes. Once you know that your patient has diabetes, you want to initiate their blood pressure medication once their blood pressure is at 130/80 or higher, and your target would be less than 130/80. The third category we have is patients who are low risk. So this is usually someone who doesn't have any cardiovascular risk factors, or they don't have any target organ damage. Usually their 10-year global cardiovascular risk would be low, so usually less than 10. So let me go ahead and write this for you guys. So their 10-year global risk is usually less than 10%. Because they are at low risk, we're not as strict anymore, so we would initiate therapy once their blood pressure hits 160/100 or higher, and their target would be less than 140/90. Now, what if your patient doesn't fall into any of those three categories? Then they would fall into here, moderate to high risk. So usually this is someone who have some cardiovascular risk factors, and usually their 10-year global cardiovascular risk would be usually between 10 to 14. So 10-year global risk is 10 to 14%. Usually for those patients, we would initiate blood pressure therapy once their blood pressure is at 140/90, and again, we're going to target less than 140/90. So this is how we can categorize your patients. If they fall into any of those categories, you now know when to initiate blood pressure therapy and what target to achieve. Thank you so much for tuning in, and have a good day.
Hi, my name is Nafia. I am an instructor here at PharmAchieve. I also work in community pharmacy, and it's my pleasure to present to you. We're talking about hypothyroidism and specifically the treatments used. What's interesting is that there are actually no non-pharmacological measures. Instead, we're replacing the hormones. So typically our drug of choice is levothyroxine. So one thing that's important with levothyroxine is counseling and administration. So we want our patients to take it on an empty stomach, ideally 30 minutes before breakfast if they can, for the best absorption of levothyroxine. It does come with drug interactions, so specifically iron, calcium, other antacids, and the bile acid sequestrant, cholestyramine. We want to separate administration by around 4 to 6 hours if we can. Now, patients may start to feel better within 2 to 3 weeks, but generally we adjust the dose every 4 to 6 weeks because that's how long it will take for TSH levels to reach steady state. Ideally, we want to avoid overdosing the patient because that's when symptoms of hyperthyroidism can start to occur. It is safe in pregnancy as well. And why is it our drug of choice instead of synthetic T3, also known as liothyronine? It's because it tends to be more stable and patients will be on this longer term. Whereas liothyronine has more kind of unpredictable pharmacokinetics, it's shorter acting, so we tend to only use it for patients who are experiencing thyroid cancer and they are no longer on levothyroxine. One thing with liothyronine that is slightly different as well is that it's not reported to interact with iron. And we don't typically give this to pregnant patients either. So the last one I want to mention is a product you may come across in practice. This is desiccated animal thyroid extract. Essentially, we want to avoid this because it leads to very unreliable dosing. It has more erratic pharmacokinetics, so it's not our drug of choice in any case. Thank you very much for listening.
Hi students, my name is Henry. I'm a pharmacist and I'm an instructor here at PharmAchieve. I've been in practice for about 2 years now, and I've worked in a variety of settings, in the community pharmacy setting, in the industry setting, and thirdly, in the education setting, where I have the great honor of being able to kind of educate students like yourselves who are aspiring pharmacists. And I thought this was a great way to kind of give back to the community because I've had so many great mentors and teachers in my life to get me to the point where I am today. So I thought I'd give you guys a little bit of a crash course on the kinetics of oral drug absorption, right? I think this is something that all pharmacists, aspiring pharmacists like yourselves, we need to know, because the vast majority of drugs are either administered or taken through the oral route. Right? We take an oral drug, gets into our system, and it's going to take some amount of time for it to start to take effect or start to take action. But have you ever wondered what goes on with that oral drug dose from a pharmacokinetic perspective? Let's dive into it. Now, in order for a pill to get absorbed into the systemic circulation, which is our blood, right? The drug in that solid form, whether it be a tablet or a capsule, right? These are the common forms of oral drugs, right? A tablet that looks like this, and a capsule, which you all may be familiar with, right? A drug in a solid form needs to get into the solution in order for any absorption to be able to take place, right? And once that pill is swallowed, it's going to travel down our gastrointestinal tract, or GI tract, where it will reach the stomach, where it's going to begin to break up, disintegrate, dissolve into the acidic environment of the stomach and the stomach's gastric fluids, right? And so one might think that once the drug is dissolved in the stomach, it's going to get absorbed at that level, which can be true for some particular drugs. But actually, there are other sites along the GI tract where drugs can get absorbed, right? And so one of those sites that we're most familiar with and where majority of our drugs get absorbed is actually the small intestine, right? But where else along the GI tract can drugs get absorbed? There's also the oral mucosa, right? Which tends to get overlooked because it's not as, frequently encountered. But we know that for majority of drugs that are in sublingual formulations, right? Majority of that absorption for that drug takes place at the oral mucosa level. Now, there are various factors that can impact the process of absorption or how drug gets into systemic circulation because of the varying properties and the varying characteristics at each of these three sites of absorption. Now, let's take a look. This figure gives you guys a nice visual overview of oral drug absorption, where an oral drug dose is going to travel down our gastrointestinal tract, where it can undergo absorption at the level of the stomach, as well as the level of the intestines, right? And I mentioned to you guys that a majority of our drugs get absorbed at the small intestines. Well, I did mention to you guys in the last slide that there's a third site of absorption that we tend to overlook, which is absorption at the level of the oral mucosa. And we know that there are a variety of drugs that are formulated to be dissolved under the tongue, which we know is sublingually. And there are also some other drugs that will get absorbed at the level of the cheek, or buccally. Now, once a drug is absorbed, and the absorption typically will occur by diffusion mechanisms, passive, active diffusion, right? The blood is going to carry that drug to the liver via what we call the hepatic portal vein. Now, here at the liver is going to metabolize the drug in a process known as hepatic metabolism, which you might recall as the first pass effect. However, the liver is not the only site where the first pass effect occurs, right? As I direct your attention to the gut wall as well, because there are certain enzymes on the wall of the intestines that are responsible for that first pass effect, right? Okay. And so that metabolism, either at the gut wall or at the level of the liver, is going to reduce the concentration of active drug before it reaches our wide systemic circulation, which we can quantify as the bioavailability of an oral drug from a pharmacokinetic perspective. I've alluded to this, but considering the absorption of an oral drug from a pharmacokinetic lens, there are two main processes that can drive that: drug dissolution, as well as drug diffusion, or otherwise known as membrane penetration. These two main drivers within drug absorption, they approximate first order processes. Now, what exactly do we mean by a first order process? A first order process is a process by which the rate of change, and in this case, the rate of absorption, so the change in the amount of drug in the body versus the change in time, is dependent on the amount of drug that's present at that moment. And so because these two main drivers within drug absorption approximate first order processes, we can fairly assume that orally administered drugs also follow first order kinetics. So as you can imagine, by that notion, as you increase the levels of drug in the body, right, or in the GI tract, you will then increase the rate of absorption proportionally and vice versa, right? And so we can describe the rate of absorption using a rate constant that we denote Ka. 2 slides ago, we touched on this concept of bioavailability. Now, bioavailability refers to the extent at which active drug enters systemic circulation, thereby accessing the site of action. Now, in pharmacokinetics, we denote bioavailability with the letter F. Bioavailability can be a range of value between 0 and 1, and it really represents that fraction of the dose that gets into the blood. And of course, with bioavailability, this can be influenced by a variety of factors. Now, the easiest way for me to remember bioavailability is by imagining how I would describe it to a grade school student. Now, the way I like to describe it is exactly how much drug the body actually sees. Now, that kind of leads us into our next very important pharmacokinetic parameter, which we will denote as the area under the curve. The area under the curve in pharmacokinetics gives us an idea of the body exposure to a particular drug. Now, the reason why we mention AUC in the context of bioavailability is because when it comes to measuring bioavailability, we need to leverage the area under the curve to be able to determine that for an oral drug dose. Now, how do we exactly do that? When it comes to measuring bioavailability for a drug, we compare the AUC, or the area under the curve, for an oral dose to the AUC for that same drug but given intravenously. And by comparing those two area under the curves, we can get a measure of bioavailability, which will be a value between 0 and 1. Now, this equation is valid considering that the same dose is given in each of those two scenarios. However, if we were looking for bioavailability of a drug for which, we're given 2 AUCs and the doses were different, we would need to account for that in our formula. Let's look at some considerations at each of the 3 sites of absorption that we mentioned in the beginning. And each of these considerations that we'll touch upon can influence the rate of absorption for an oral drug. Now, we start at the left here at the bottom, at the level of the oral mucosa, like we mentioned, right? This is an area that's very highly vascularized. It has very thin epithelial layer, very thin tissue. So you can probably imagine for an area like this, the absorption of it is going to be very highly enhanced, right? And so that's why there's some variety of drugs that are preferentially, right, absorbed at the level of the oral mucosa, either buccally or sublingually, under the tongue or in the inner cheek, right? But for a majority of their drugs, they're going to get swallowed, travel down the gastrointestinal tract, where it's going to encounter our stomach. Now, our stomach is an organ that has a large surface area, so you can probably imagine for an area that has a large surface area, probably more opportunities for absorption, right? However, there's other variables that we have to consider when it comes to the rate of absorption for a drug, right? Because now we're dealing with an organ that has a very thick tissue, thick epithelial and thick mucus layer, right? But we're also exposing the drug to gastric contents that's, 1, acidic, right? As well as is enzyme containing, right? Because there are maybe proteases, other enzymes within the gastric fluids that can further degrade drugs and hence, reduce the bioavailability of our drug, right? So for majority of our drugs, I mentioned in the beginning, are going to get absorbed at the level of the intestines. And we know that the intestines is a very large organ, right? Very long in length, right? And it's also very highly vascularized. So many opportunities for absorption. However, absorption at the intestines can be limited by things like gastric emptying, right? Or even patient-specific factors, right? If patients have gastroparesis or some other medical conditions that impair gastric emptying, that can impair the absorption at the level of the intestines, right? We also know that things like food can also impair or influence the absorption of a drug, can either decrease the absorption or increase the absorption, as we know for a variety of drugs. which is why it's very, very important for us, and as well as for you students as aspiring pharmacists, when it comes to, counseling on very, very key points about a new medication for a patient, that you know exactly, whether that, drug should be taken on an empty stomach or with food. So the graph that you can see here is what you can visualize in terms of the plasma concentrations versus time curve for a single dose that's administered through the oral route, or PO for oral. Okay. So a patient takes some form of an oral drug, and we start obtaining blood samples at varying time points to be able to kind of plot a graph similar to what you see here. Now, in light of the kinetics of oral drug absorption, there are some notable features of this graph that I want to point out, right? We have the point at which t is equal to 0, so the point at which the patient took the oral drug. The point at which the drug reaches its peak plasma concentrations, as we otherwise denote Cmax. And that period between t equals 0 to the point of Cmax is what we refer to as the absorption phase. In the absorption phase is when we start to see that slow buildup of the levels of drug in the plasma. And that's when we start to get that settling of that equilibrium between the blood plasma as well as the body tissues. Now that equilibrium is established at the point of Cmax, at the maximum peak plasma concentration. And once we attain that peak plasma concentration, the levels of drugs are going to start to fall, denoted by what we call the elimination phase, when the drug is starting to eliminate out of the body. So as you can see, for an oral drug, there are two phases to consider when it comes to the pharmacokinetics of oral drugs. We have the absorption phase as well as the elimination phase, both of which have their own respective rate constants that we have to consider when it comes to the equation that we'll see in the next slide, right? And so I also wanted to kind of show you the area under the curve, right? Because it was a very important pharmacokinetic parameter that we mentioned when we talked about bioavailability. Now the area under the curve is just that, the area under the curve. We have a curve, plasma concentration versus time curve for an oral drug. The area under the curve is everything that I'm shading under this curve, right? And obviously now we have technologies and systems to be able to kind of calculate this for us. But obviously back in the time, right? Back in the time, mathematicians, they were doing this all manually, right? Where they would take 2 points on this curve and be able to kind of capture the area between those particular time points and then add them up over as time goes on, right? So the area under the curve is just that, and we use the area under the curve as a measure of body exposure to the drug, which we can then use to find the bioavailability for our drug. Now, like I said, we do have an equation to really describe that plasma concentration of drug after some time t, right? For an oral drug in a single compartment system. Now, an equation like this, just looking right off the bat can look quite complicated. And this is because we have two phases to account for, right? We have the absorption phase as well as the elimination phase that we need to account for in our formula. Right? The absorption phase, which we can denote as Ka, right? Which we saw was the rate constant of absorption, as well as the elimination phase, which we can denote as K, or sometimes otherwise termed KEL with a subscript EL. Okay? And so in this formula, we are accounting for F, the bioavailability, the dose of the drug given by D, the rate of absorption, the volume of distribution of our drug, as well as the elimination rate constant. And then last but not least, the time, right? The time at which we're capturing that plasma concentration for an oral drug. Now, I hope that gives you, a very, very high level overview of the kinetics of oral drug absorption. And thank you so much for listening.